Good morning, everyone. I'm Jessica Kim Cohen, a reporter at Genomeweb, and I'll be your moderator today. The title of today's webinar is Advancing Precision Oncology Through Genetic Panels, Comprehensive Evaluation and Patient-Centric Care, and is sponsored by BGI Genomics. Our speakers today are Benjamin García-Bloj, head of the Cancer Genetics Unit at Clínica Los Condes and director of the Center for Precision Oncology, and Ahmet Uludağ, chair of the board of directors and responsible manager at NGC Genetic Diseases Evaluation Center. You may type in a question at any time during the webinar. You can do this through the Q&A panel, which appears on the right side of the webinar presentation. If you look to the bottom tray of your window, there are a series of widgets to enhance your webinar experience. And with that, I'll turn it over to Dr. García-Bloj.
Thank you very much for the invitation and the opportunity to talk about this importance of the hereditary cancer testing in the development of precision oncology programs at the international level. With that, I would like to present a little bit of an outline. We want to discuss a little bit about the testing itself. What are we using in terms of NGS panels in the clinical setting, especially from my point of view as a physician and genetic counselor? What are the benefits of hereditary cancer testing in precision oncology? And to top it off, I want to discuss a very interesting case study that I faced recently, where I think all the things we are going to discuss previously are going to make sense in the real world, right? And finally, my conclusion. So when we talk about testing about hereditary cancer, it's because we want to identify if there are mutations that could lead to a predisposition or an increased risk of generating a potential tumor and a special kind of syndrome of hereditary cancers. Especially the most known ones are, for example, breast and ovarian cancer, the Lynch syndrome that is associated with colon cancer. So we see in the span of the lifetime, some patients have an intrinsic mutation process that could potentially increase their risk. So the significance is very important because there is an early risk assessment that we can do with these patients, so we can start planning ahead and be a little bit more proactive in terms of either detecting very efficiently or even preventing those cancers from arising, so that patient has a full life, right? That's beside the somatic presence of cancer that is, my colleague is going to talk a little bit more. So we tend to have a glimpse of the personalized care we can have, not only with the patient that sometimes asks us for the consultation initially, but also for the family and the family planning in terms of children and siblings. So if we view these common hereditary cancer syndromes, I already mentioned the breast and ovarian cancer, mainly assigned to BRCA1 and 2, but over time we have seen that many more genes are involved in this risk of producing breast and ovarian cancer, and also more tissues that are maybe at risk of developing tumors, such as pancreas, skin, and other tumors that we need to prevent and have some kind of personalized observation. So in this context, we have the consensus reached in Envision that what we try to do is this risk assessment through family history, personal background, clinical background, obviously, and also the genetic testing. And this risk stratification allows us to have interventions tailored to those risks, either like scanners or mammographies, for example, the timing when we start, or even surgical procedures that we could eventually adapt, like treatment, prophylactic treatment, such as mastectomy, bilateral mastectomy before the cancer even appears. So generally, the systems that are affected are repairing system for the DNA, such as the mismatch repair system in the Lynch syndrome, or the homologous recombination deficiency for BRCA1 and 2, and many more genes associated with those. In terms of the clinical usage, we tend to use multi-gene panels, and this, from the point of view, the larger the better. And that's because when we see at the NCCN guidelines, the choice of the multi-gene panels is already backed by evidence that is more efficient, more cost efficient, and also clinically efficient, because we tend to find these mutations much more often than when we just use certain very limited panels where we use to sequence 1 or 2 genes, or maybe 9 or 10. So we tend to favor the ones that are look for many genes, so we can find sometimes pathogenic or likely pathogenic variants in a more broad spectrum. Okay, and the disadvantage of this is that sometimes we could find some variants of uncertain significance, but this can be talked with the patient at the pre-test genetic counseling, so the patient knows that there is some clinical utility that we are going to see over these variants, and they are more prepared before the results of variants of uncertain significance, that they are not going to have a very much an influence in the clinical aspect for that patient in particular. But it's very interesting to know, especially in our countries, that we have lack of databases, and some variants doesn't appear in the more common panels because we're just now sequencing Latin American patients, and we are uploading these variants as far as we get to know them, And the benefit is for tending to have larger panels, more than 80 genes, where the region are captured with more efficiency, and open to see regions that are not normally mutated in other kind of patients, especially in northern hemisphere patients. Also, the databases are very important in this aspect, because we need to have oncology databases that are more pertinent to our populations. In our case, the Latin American population, but they need to have more practical experience with the treatments and the significance of these kind of mutations. So I wanted to mention, for example, that early detection of breast cancer also offer the possibility of personalized treatment, such is the case with PARP inhibitors, where we have the clinical trials, Olympia and Olympiad, where these PARP inhibitors were registered using these multi-gene panels in terms of identifying homologous recombination deficiency, for example, in BRCA1, BRCA2, PALB2, and other genes involved in these molecular pathways. And those are either at the somatic or the germline level. So it's very important for us. And these global collaborations are very important, such is the case, for example, for the Wayfinder initiative, where we are participating in a global collaboration to upload this data in terms of understanding what are the germline variants that we are seeing in our population. And this is a collaboration over more than 15 countries and more than 100 sites. So this is the kind of example where we have been participating as a Center of Oncology, Precision Oncology. And other examples is those where we uploaded our data in terms of specific cancers like gastric, yeast, or other kind of actionable target rates in the Chilean population. So these efforts are very important in terms of getting to know what is the genetic makeup, the genetic landscape of our special Latin American people. And this must be very carefully done in terms of how we construct this database of variants and how the ethic committee needs to oversee our data custodians in order for us to share this at the clinical and researcher level in order to improve the human health and medicine of our patient and also from our neighbors in our part of the world. Now, if we want to go specifically in the hereditary cancer, we are going to talk a little bit of the benefits that we see when we test our patients. So in this slide, you can see that we have mainly three kind of big objectives, right? We are allowed to do early detection, and that could lead to prevention at one of the three levels that I'm going to talk at the end of my presentation. Most importantly, the familial risk assessment, because that familial risk assessment allows us to put some of the patients in our high risk for developing cancer, so they tend to have personalized prevention plans. And also, what I'm going to talk in the case study is the personalized treatment planning from the hereditary cancer testing. So this is very important because this is where our side of genetic counseling talks with the oncology part and even the surgery department. And this allows us, this is allowed because the advancement we had in genetic testing technologies is that our NGS technology covers more and more genes, more and more areas. And in fact, we have expanded genetic insight because of the new genetic biomarkers in terms of homologous recombination markers, in terms of how even the tumor or the patient have a little bit of homologous recombination deficiency in different aspects or mutational signatures. And the industry actually is moving that eventually we are going to do more whole exome sequencing for actually assessing the risk. So the more bigger the panel that we're going to use is more on this kind of trend. Now, I want to present this case study because it sums up what we've been talking. You have this patient in red, is a 37 years old female with the diagnosis of a breast cancer. And this breast cancer was luminal B breast cancer. And when we saw her, she had an oligometastasis in the vertebrae. And she actually was positive to BRCA2, and a very little known variant, but it's pathogenic nonetheless. And this patient was already after treatment, after systemic treatment, he underwent surgery and radiotherapy on the metastasis with a very good clinical outcome. The thing is that when we tested the family, we saw that her fraternal twin didn't have the variant, but her younger sister did. So we have now a female with 31 years old with a positive BRCA2 pathogenic variant. And from the parents, the mother was negative to this variant, and the father is suspected. He didn't want to do the sequencing, but is suspected to have it for both sisters to be able to be the carriers, right? So here I mention it because sometimes, I don't know in other parts of in the world, but in Chile, sometimes the the males don't want to undergo this kind of testing. And it's very important because BRCA2 is has a high risk of developing prostate cancer on a more advanced stage or a little bit more aggressive. But if we see the result that we obtained from the test, that we had a nonsense mutation, which is very deleterious, very pathogenic, and this eventually allows us to have the risk assessment for this patient, but also for the sister. So if you see on the left side of the slide, we see that we can actually mention that the risk of developing cancer to the age of 50 is around 35% compared with the population of only 2%. But when we see up to age 70, these risks can go up to 87.5%. So that's why we need to implement some kind of risk management on the carriers of this variant. In terms of awareness, we are going to begin at 18 years old, starting with the clinical breast exams by the 25 years, and the breast MRI should start around 25 to 29. We tend to do it at least 10 years before the first case. So since the sister had her breast cancer at 36, we need to start at the most at 26. So we are ready 5 years later on the youngest sister. And we are gonna alternate with the mammogram with the MRI. And especially, we need to discuss the option of the reduction of mastectomy. And we are going to see some of the guidelines, for example, that the risk reduction surgery should be carried out, for example, at 40 years old. And also, we need to discuss the possibility, because of the high risk of presenting ovarian cancer, of doing the risk reduction of bilateral salpingo oophorectomy between 40 and 45, always fulfilling the family planning of the patient. So that takes priority. In terms of the sister needs to, since we have been able to assess her risk, we need to do the risk management with either surveillance. That's the case she's right now. And we have been planning the surgeries for more or less the 40 years old. And in terms of the patient that she already has cancer, we need to modify the treatment for her because she's oligometastatic. So she's going to start in PARP inhibitors in terms of maintenance, because there has been a lot of improved outcomes in those patients. So you see, from one test in one of the patients, we have been able to treat the whole family in terms of management of the risk and modifying the treatment of the patient herself. So it's very important. And here's where I tend to explain both the patient and the rest of the medical team about this kind of 3 layers of prevention. Because you have the primary prevention, where you're going to try to modify the habits, the lifestyle, try to improve certain things that could be protectors for the patient, like the physical activity, diet, tobacco cessation. But also you have secondary prevention, more oriented to detecting in a very early stage, and that's where the very early mammographies, MRI, or endoscopies tend to play a big role. And in terms of tertiary prevention is what we're doing with the index case, in this case, the patient with the breast cancer, where we added targeted therapies like the PARP inhibitors in a BRCA2 mutated patient at the germline level. So we can see in this case study all 3 levels of prevention personalized thanks to the hereditary testing. So in conclusion, I wanted to mention that we need to have further integration, especially in countries where we're starting to sequence our patients, sharing our data, understanding what are the drivers of these genes, and further collaborate with the multiple medical centers as we're doing. In terms of the role of hereditary cancer, I think it's very important for the teams managing oncology patients to have the genetic counseling, the hereditary testing panel, because it gives this insight that could eventually prevent or more effectively treat the patients. And these advancements that are occurring at global scale, we need to bring it to our countries, and that way take advantage of the technological advancements, but also embracing the collaboration between our countries. So with that, I want to leave my colleague, Ahmet, to continue the presentation in precision oncology.
Thank you very much. Good morning, good afternoon, and good evening to all followers, because I see they're all followers from all over the world. And today I want to mention about advancing precision oncology in Turkey, NGS technology and clinical significance. Having accepted the principle that the cancer is a genetic disease, regardless of its etiology, we accept that the dynamics of each cancer are different. So precision oncology tailors cancer treatment to the individual characteristics of each patient. It denies one-size-fits-all approach, recognizing that every cancer case is unique. Of course, we have challenges of conventional cancer treatment, because conventional cancer treatments do not consider the specific genetics and molecular makeup of each patient's cancer. They often result in side effects and suboptimal outcomes. What is the role of NGS technology? Next generation sequencing, NGS technology, is a revolutionary and allows for the comprehensive analysis for a patient's genetic and molecular profile. How can we use NGS in precision oncology? NGS helps identify clinically actionable mutations within a patient's tumor, enabling more targeted therapies. More importantly, it aids in the discovery of new treatment targets. The promise of precision in oncology. The precision oncology driven by NGS technology offers the potential for the improved treatment outcomes and the higher quality of life for cancer patients. Precision oncology is an innovative approach to cancer treatment that customizes medical care for each individual based on their unique genetic, molecular, and clinical characteristics. Precision oncology gives us optimized therapies, reduced side effects, improved outcomes, and overcoming drug resistance. Conventional cancer treatments may not be effective for all patients, as we know. And precision oncology gives us a chance to targeting the underlying molecular cause. Precision oncology places the patient at the center of care, taking into account their unique needs, preferences, and genetic makeup. As a definition, clinical actionable mutations are genetic alterations in a patient's tumor that have known therapeutic implications. Identifying these mutations is very critical for precision oncology because they guide treatment decisions. By pointing the clinically actionable mutations, oncologists can select treatments that specifically target these genetic changes, which leads to more effective and less toxic therapies. Let's some examples for clinical actionable mutations, like EGFR mutations in lung cancer. Patients with EGFR mutations in lung cancer may respond to EGFR inhibitors like erlotinib, which has significantly improved survival rates and quality of life. And HER2 amplifications in breast cancer, for example, patients with HER2-positive breast cancer are candidates for HER2-targeted therapies such as Herceptin. And BRAF mutations in melanoma, BRAF inhibitors like Genomeweb has shown remarkable efficiency in targeted melanoma patients with BRAF mutations. It has extended the survival of patients with advanced melanoma. Of course, identifying and targeting clinically actionable mutations enhances treatment response because the therapy is specific for molecular characteristics of the tumor. So this often leads to better quality of life and improved prognosis for the patient. And understanding the genetics of a tumor allows to adapt treatment strategies as needed, helping overcome issues like drug resistance and reducing the risk of recurrence. Unfortunately, we are all at the beginning and still do not have precision medicines for all cancers. Discovering new treatment targets is essential, and our primary mission to expand the range of therapies available to cancer patients. Next generation sequencing technology plays a critical role in the discovery of new treatment targets, and NGS allows for comprehensive and detailed analysis for the genetics of tumors. Let's see some examples of how NGS aids in discovery. NGS can access tumor mutational burden, TMB, which is a measure of genetic mutations in tumors, and high tumor mutational burden indicate a potential response to immunotherapies. And also MSI, microsatellite instability. NGS can identify microsatellite instability status, which can guide to use of immune checkpoint inhibitors like pembrolizumab in colorectal cancers. And gene fusions like ALK and ROS1 in non-small cell lung cancer, targeted therapies like ALK inhibitors can be used for the therapy. And identifying new treatment targets through NGS expand the range of therapies available and improves the chance of success. Treatments so specific molecular characteristics of the tumor made possible by discovering new targets can lead to better treatment responses and improved quality of life. And genetic panels, including several genes, are comprehensive tools in precision oncology, allowing for a true analysis of a patient's genetic and molecular profile. They play a vital role in personalizing cancer therapy. Genetic panels often use next-generation sequencing, NGS technologies, to analyze multiple genes and genetic variations. And genetic panels assess genetic risk factors by identifying germline mutations, also like my colleague told. Genetic panels help clinicals select the most appropriate treatment based on the patient's genetic profile in wide scale, and also can detect individuals with a higher genetic predisposition to certain cancers and allows for more vigilant screening and preventive measures. And also, genetic panels can identify early stage of tumors in some cases. It's essential to consider ethically privacy and concealing aspects when using genetic panels, because this is a really challenge. Also in Turkey, the result can have far-reaching implications for both the patient and the family. So concealing must go on long term, maybe years and maybe in generations. And also genetic panels contribute to patient-centered care, to the approach. It's a heart of precision oncology. Why Turkey is an integrating context for precision oncology? Turkey is a home to a diverse population with a rich tapestry of ethnic backgrounds. The diversity extends to genetic variations, making Turkey a unique genetic landscape. And what's the cause of this genetic heterogeneity? The genetic makeup of Turkish population exhibits subnatal heterogeneity with various subpopulations because of history, geography, and etc. As you know, Turkey was the capital of one of the greatest empires in history for hundreds of years. So lots of people interact for a long time. Also, Anatolia has always been one of the most important historical migration routes. Even today, millions of immigrants in Turkey from South Asia, Middle East, and even Africa. The diversity impacts the prevalence and types of genetic mutations seen in cancer too. The diversity presents both opportunities and also challenges in precision oncology. And because of this diversity can lead to discovery of rare mutations and genetic variants that are not as common as homogeneous populations. So there is a potential for uncovering new treatment targets. Precision oncology in Turkey embraces a patient-centered approach and developing day by day. The unique genetic characteristics in Turkey make it an attractive region for global collaborations and research in precision oncology. And of course, we have challenges about this, such as large-scale data collection and the translation of research into clinical practice. As my colleague told detail before me, that's why I'm skipping this session. A patient-centered approach places the patient at the center of the care, recognizing their unique needs, preferences, and values. It fosters collaboration between patient and healthcare providers. And cancer treatment to individual genetic profiles is a hallmark patient-centered care. It considers each patient as a unique case, leading to more precise and effective treatments. And what are the benefits of patient-centered care? They are optimized outcomes, reduced side effects, improved quality of life, and enhanced decision-making. So what's the role of NGS technology? NGS enables the in-depth molecular profiling needed to patient-centered care. It provides the genetic data required to make informed treatment decisions. Patient-centered care values the patient's goals and values in decision-making. It takes into account patient preferences regarding treatment options, quality of life, and side effects. And holistic approach is very important for cancer treatment nowadays. Patient-centered care is holistic, considering not only the disease, but the individual's physical, emotional, and psychological well-being. So it supports the overall health of the patient. And a patient-centered approach often includes psychological support, such as counseling and supporting groups. When we look at the challenge, we see that costs are still high, especially in Turkey. We hope that the development in NGS technologies will reduce the prices. There are several kinds, brands, and systems in the world for precision oncology. While choosing the correct one, we have some tricks. As large as the panel, as much as drug opportunities. So having chance to treatment, for example, in study about colorectal cancers, Lyle and colleagues declared that it's 99% for detection of driver genes positive rate. So the largest panel, the panel wide is very important. It's also important to approach comprehensively. Not only point mutations play a role in selecting the right treatment, but also fusions, CMVs, MSI, tumor mutation burden are also important too. Tumor mutation burden represents the number of mutations per megabase harbored by tumor cells in a given neoplasm. So as you see, it's an average number. So the larger the area we sequence, the healthier ratio we get. As MSI is the same, the more regions we investigate, the more chance we have to discover. As you see, Sentis Cancer Discovery Panel includes 688 genes. It's one of the largest in the market. And this is one of a patient's result. I will show some important place of this result. More or less, you are all familiar with somatic mutation analyzer reports. Here you see the Sentis Cancer Post Discovery Panel report. On the first page, you can see the summary of the report, and all important information are in this page. So in fact, a clinician can act with only the first page in the report. Then details of the report comes, second and the following page. As you see here, clinically significant variants are listed. FDA-approved sensitive and resistant drugs are shown. Additionally, clinical trials of phase 2 and phase 3 are also shown, so the researchers can contact with them. As you know, tumor mutation burden values and limits must be evaluated differently for each cancer. In here, it's shown for the breast cancer. In this page, the sample evaluated for immunotherapy. You can see both positive and negative correlations genes of immune effect. They are all considered. And drug metabolism, enzymes, and the situationally is very important for cancer therapy. In Sentis, you can find a chapter for the situation for those genes. Variant of insignificance at the right are very important because knowing the reporting those variants, they can be evaluated for the patients, especially no actionable mutations found. The comments about those variants can illuminate clinicians for rare cases. Evaluating them are very important to find new actionable mutations too. In Sentis reports, you can find detailed information about potential positive drugs. They can be FDA approved or FDA approved for different types of cancer or cause resistance for clinical trials also. And detailed information given in the report about considerable clinical trials to be involved, to be the part of a development of a new drug is very important, as you guess. And challenge and charting of the future. What are the challenges in precision oncology? First, infrastructure and resources. Building and maintaining the necessary laboratories for precision oncology, including NGS technology, is the first challenge. And data management is also a challenge. Managing vast amount of genetic and clinical data is also a problem. And accessibility, equal access chance to precision oncology, particularly in remote or underserved areas. And also regulatory and ethical issues, addressing regulatory and ethical considerations, especially serving to underserved places, For example, transferring the sample or data to abroad can be problematic. Interdisciplinary collaborations can be a problem also. Effective collaboration among multidisciplinary teams, including geneticists, oncologists, and researchers, is not easy all the time. Research and data sharing is very, very important. Collaborative research and data sharing within Turkey and globally are vital for advancing precision oncology. And clinical trials and therapeutic innovations also important. Conducting clinical trials that are incorporate precision oncology approach in a priority for identifying new treatment targets and therapies. Conducting clinical trials also important, and increasing public awareness about the benefits for precision oncology and the availability of NGS-based testing are very important. And patient advocacy groups can play a crucial role for promoting precision oncology and advocating for better access and supporting patients. And also global collaborations, as you can guess. Collaborating with informative organizations and researchers can accelerate advance in precision oncology. And long-term goals, Turkey's long-term goal is precision oncology, include reducing prices, expanding data sharing networks, and increasing the integration of precision approach in clinical practice. And the vision is to make the precision oncology a standard of care for all patients. And what we have to take from this presentation, precision oncology impact, it's transforming cancer care by customizing treatment based on individual genetic and molecular profiles. And clinical actionable mutations are crucial for targeted treatments, improving patients' outcomes, and reducing side effects. New treatment targets, we have to be open for new treatment targets. NGS technology expands the therapeutic options by discovering new treatment targets, offering hope to those with limited options. Genetic panels play a pivotal role in assessing genetic risk factors and personalizing cancer in risk assessment and early interventions. And for Turkey, don't forget Turkey's unique context. Turkey's diverse population and genetic variations make it a critical content for precision oncology, offering new insights and treatment options. NGS technology has a revolutionized precision oncology, and NGS technology also enhances the accuracy of cancer risk assessment, allowing for early interventions and improved patient prognosis. And we have also challenges include infrastructure, data management, accessibility, and regulatory issues, and of course, costs. For the conclusion, Turkey is poised to advance precision oncology guided by patient-centered care and empowered by NGS technology. The vision is to make precision oncology accessible, effective, and standard care for everyone. Thank you again for giving me this opportunity. I hope it was useful for you. And in front of you, I want to congratulate all Turkish citizens for the 100th anniversary of Republic of Turkey. And these are some views of Magic City Istanbul. If you haven't seen yet, I recommend to see. Now I'm waiting for your question, and also please feel free to contact me by this email. Thank you very much.